Welcome back. This is Ian Bodford.
And Liang Lu.
And this is the clinical correlation. Today's case is...
This is a 75-year-old male who presents with hematuria. For the past day, he has been passing blood clots in his urine.
Upon chart review, you note that he has a vague history of cardiac surgery and is on warfarin.
Walking into the room, you see a urine sample in a specimen cup at the bedside that contains bright red urine. He is tachycardic and no blood pressure reading is seen on the cardiac monitor.
To confirm his tachycardia, you grab his wrist, only to find that he does not have a radial pulse. He remains alert and is having a conversation with you.
That's odd. Upon lifting his shirt, this is what you see.
A left ventricular assist device, or LVAD, was developed in the 1960s as a bridge to heart transplant. Over the years, they have evolved into a permanent solution to heart failure, also known as destination therapy.
Recipients of LVADs typically have New York Heart Association Class 4 heart failure and an ejection fraction of less than 25%. LVADs are the most common assist devices, but right ventricular assist and biventricular assist devices do exist. The goals of all assist devices are to augment cardiac output.
The devices contain three variables, which are speed, flow, and power.
These variables are modified by the components of the LVAD. The pump, which is generally situated in the peritoneum, takes blood from the left ventricular apex and pumps it to the aorta.
The driveline is the cable that enters the skin and connects the control unit to the pump.
The controller or control unit is the external computer that monitors the performance of the pump. It is also where the settings of the pump are selected. The control unit also has alarms that will sound if the pump malfunctions or is low on battery. The display shows the pump speed in revolutions per minute and the output of the pump in liters per minute.
Finally, the power supply is a battery. It powers the controller and pump. Generally, patients carry multiple batteries with them, and most LVADs have a way to connect to a wall outlet for permanent power.
So why do these patients present to the emergency department? The most common pump-related presentation is bleeding, with almost half of LVAD patients presenting with bleeding at some point. All will be on anticoagulation to prevent pump thrombosis.
The most common bleeds are epistaxis, gastrointestinal, intracerebral, and intrathoracic bleeding. Aside from supertherapeutic anticoagulation, patients can develop acquired von Willebrand's disease. The lack of pulsatile flow can also lead to AV malformation in the GI tract.
If a patient presents with a bleed, contact their VAD coordinator. All LVAD patients should have this information on their person. Anticoagulation can be reversed in LVAD patients without much risk for acute thrombosis. Consider using TXA, PCC, FFP, and desmopressin in life-threatening bleeds.
Patients with LVADs can also present with infections. The driveline and pocket where the pump lays are the most common sites for infection.
The infections are mostly caused by gram-positive bacteria, but coverage should be broad and include antifungals until a source is identified.
One of the most feared complications is thrombosis of the pump. This will manifest as increased power consumption from the pump, known as power spikes. There will also be a low output state from the pump and increased pump speeds required to maintain adequate flow. A smear of the patient's blood might also show hemolyzed red cells.
Diagnosis is made with an echocardiogram, but a cardiac CTA can also be used. Treatment is with heparin and antiplatelet medications. TPA can be used in life-threatening situations.
Arrhythmias are not uncommon in patients with LVADs, including atrial fibrillation and ventricular arrhythmias. Electrolytes and troponin should be evaluated in any patient with an arrhythmia. Treatment of AFib is the same as in patients without LVADs.
Ventricular arrhythmias are treated with volume resuscitation and possibly pharmacologic or electrical cardioversion. If electrical cardioversion is deemed necessary, the patch should be placed in the anterior-posterior position.
A lot of patients with LVADs also have ICDs in place. They can possibly present with improper firing of their ICDs from LVAD interference.
Evaluation of patients with LVADs should be somewhat systematic. Assess how well they are perfusing by their mental status and capillary refill. LVAD patients are dependent on preload, so most of them will be fluid responsive.
Heart rate can be assessed with an EKG, as auscultation is made difficult by pump noise. Generally, the LVAD does not interfere with the heart's underlying rhythm on EKG.
Blood pressure must be measured with a manual cuff and Doppler ultrasound. The MAP is identified when the constant flow returns. MAP goals for LVAD patients is between 70 and 90 millimeters of mercury. This can also be monitored using an arterial line.
Labs, including coags and troponin, should be sent when deemed necessary. Look at the patient's controller to see their parameters.
These include pump speed, power, flow, and pulsatility index. The pump speed varies by device, but is usually between 2,000 and 10,000 RPMs. The power is between 4 to 6 watts and the flow is between 4 to 6 liters per minute. The pulsatility index measures how much pulsatile flow is provided by the patient's heart. It is between 1 and 10, and the higher the number, the less the LVAD is supporting them.
Always contact the patient's LVAD coordinator and have those numbers handy when you do.
In the unfortunate case of a patient in cardiac arrest, evaluate all components of the LVAD and make sure all lines are connected. Attach the controller to a reliable power source. Follow the ACLS algorithm as with other patients.
Avoid chest compressions unless they are absolutely required. Make sure to evaluate all causes of pump failure and hypoperfusion prior to starting compressions. It is thought that manipulation of the chest wall can damage the LVAD components and even lead to disconnection from the heart and exsanguination.
Recent studies have shown that compressions are generally not as harmful as once thought, but more evidence is needed.
To summarize, the components and variables of the LVAD are important to understand when patients come in with complications.
The main complications are bleeding, infection, pump thrombosis, and arrhythmia.
Every LVAD patient should have their coordinator's information on their person. Contact them as soon as the patient comes into the ER.
If the patient arrests, follow the ACLS pathway, but make sure to exhaust all reversible causes prior to starting compressions. So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
And me, @EMLLou.
Thanks for listening.